The concept of early molecular response will remain important, but what is going to change is the way we define early molecular response. Because in recent years, it has become more and more evident that a single measurement at 3 months cannot be a reliable indicator of how our patient will fare. What is much more informative is the kinetics of BCR-ABL. Given that the actual baseline of each individual patient may vary greatly, at least 2 measurements are needed to look at the kinetics, but even better if they are 4, at baseline and each month for the first 3 months. Besides early molecular response, we also have 2 other important molecular response milestones: major molecular response and deep molecular response. Major molecular response is the so-called safe haven for survival, and deep molecular response is also very important because it's a key prognostic factor by itself, and it's also the gateway to treatment-free remission, which is really becoming an important goal of CML therapy nowadays, both from a patient perspective and from a pharmacoeconomic perspective. I'm sure it will, but such an approach would require switching from a control gene other than ABL, ideally Cas-B. This is because the reaction that amplifies the ABL control gene also co-amplifies BCR-ABL, which leads to an underestimation of the actual BCR-ABL to ABL ratio at the early time points when BCR-ABL is high. And this is important because most of the labs in Europe are currently using ABL as a control gene. And also in many labs, we do not measure the individual baseline of our patients. Additionally, more data are needed to define the exact threshold in transcript reduction in imatinib-treated patients and in second-generation TKI-treated patients. Now, definitely it doesn't. We should go on monitoring our patients on a regular basis, every 4 to 6 months, as it is also stated in the ELN recommendation. And this is because a BCR-ABL transcript increase at any time point during therapy should trigger further investigations. A BCR-ABL transcript increase leading to a confirmed loss of major molecular response, for example, should trigger a BCR-ABL kinase domain mutation screening. Additionally, a transcript increase at any level might also be a sign of non-compliance, so in such a case, patient adherence should be carefully investigated. MRD monitoring is an important prognostic parameter also in Ph-positive ALL patients. There is increasing evidence that MRD monitoring gives precious information to identify those patients who should undergo allogeneic stem cell transplantation and those patients who need post-transplant therapy. Real-time quantitative PCR for BCR-ABL transcript level is the gold standard also for Ph-positive ALL MRD monitoring, but Ph-positive ALL lags behind CML in this regard because standardization efforts have started much more recently. Mutations tend to cluster in the kinase domain of BCR-ABL, and in imatinib-resistant patients, we have observed more than 70 different mutations, which means that not only the critical contact points between BCR-ABL and imatinib, but not only critical areas like the P loop and A loop are involved. Mutations may occur in any region, leading to a change in the three-dimensional structure, impairing TKI binding. Second-generation TKIs have much less resistant mutations, but still they retain a certain number of critical Achilles heels. Mutations are not induced by TKI therapy, they are simply selected by TKIs, and the greater is the number of Achilles heels, the greater is the chance that the TKI will select for a resistant mutation. Yes, the ELN recommendations suggest to use conventional Sanger sequencing for BCR-ABL kinase domain mutation screening, But this is just because the recommendations were written in 2011, and at that time, nobody could have ever imagined what a revolution benchtop next-generation sequencer were about to bring in a 5-year times in routine diagnostics. As compared to Sanger sequencing, next-generation sequencing is more sensitive and it's quantitative. The greater sensitivity has been demonstrated in several publications down to 1%, and not only in single lab experiences, but also, and more importantly, also in multi-lab experiences. Another interesting issue of NGS as compared to Sanger is the possibility to discriminate between compound and polyclonal mutations. There is accumulating evidence coming from several publications and Congress abstracts that the greater sensitivity of NGS is indeed clinically relevant. In CML patients with the failure response, NGS may paint a more accurate picture of BCR-ABL kinase domain mutation status that is likely to enable a better choice of the subsequent TKI therapy. In patients with warning, NGS may help identify those patients who will turn into failures. Additionally, NGS has been shown to be able to detect emerging mutants 2 to 11 months before conventional Sanger sequencing, especially in those patients with increasing BCR-ABL transcript levels. And more importantly, there have been no reports of low-burden mutations not selected under the TKI they confer resistance to. So low-burden mutations are clinically relevant. The prognostic value of low-burden mutations had already been investigated in the pre-NGS era in a study by the Australian colleagues published in JCO in 2011. They had used mass spectrometry to look for the most frequent TKI-resistant mutations and had found that detection of low-burden mutations indeed predicted poor inferior outcomes. Additionally, there is a more recent study based on NGS by Dr. De La Valade and his group, a prospective study in which they showed that detection of low-burden mutations by NGS down to 3% in patients with a complete cytogenetic response but not major molecular response was significantly associated with shorter progression-free survival. Yes, we do have the ELN recommendations and also the US NCCN recommendations. As far as CML is concerned, mutation screening is recommended in case of failure and according to ELN also in case of warning. And as far as Ph-positive ALL is concerned, mutation screening is recommended in case of relapsed or refractory disease. According to our experience, mutations are not so frequent in patients who are in chronic phase, less than 1/3 of the cases, but they become more frequent in patients with accelerated phase and blast crisis, when almost 75% of the cases may be positive for a mutation. Also, there is an important difference between primary and acquired resistance. Mutations are much more frequent in patients with acquired resistance, that is, patients who lose a previously achieved response, as compared to patients with primary resistance, which means those patients who do not achieve the major response milestones. Ph-positive ALL resembles CML blast crisis because genomic instability is equally high in both diseases. According to our experience, in Ph-positive ALL, mutations can be detected in up to 60% of the cases who develop resistance to imatinib, and the figures grow to almost 80% of patients who fail a second-line TKI therapy. T315I and P-loop mutations are the most frequent ones, and patients with multiple mutations are definitely frequent, especially in patients who fail second-line TKI therapy. Yes, it is, because in this way we can not only look at the complexity but also follow the kinetics of the mutant clone over time. This is important to prevent relapse in certain cases, for example, in patients already harboring mutations undergoing second-line TKI therapy. It is also important in all those cases in which we find a mutation with an unknown IC50 and an unknown resistant profile to understand its real clinical meaning. First of all, in Ph-positive ALL, low-burden mutations can be detected since the time of diagnosis, although the percentage that have been described in different studies are different. Also, as I mentioned before, P-loop and T315I mutations are the most frequent, and the emergence of mutations may be as quick as in 4 to 6 weeks. Taken together, the greater complexity and the swift emergence of mutations requiring a timely decision-making pose a clinical and diagnostic challenge in Ph-positive ALL. So I really think that in this setting, an MRD-driven NGS BCR-ABL kinase domain mutation screening would be really helpful to optimize treatment outcomes. Yes, I would definitely advise changing the TKI if we found a TKI-resistant mutation, whatever the percentage of the mutant clone, in order to be able to prevent relapse of the patient before it is too late. We do know which mutations are resistant to which inhibitor, and we also know that in case of multiple mutations, second-generation TKIs are going to fail, but not ponatinib. Yes, and I think digital PCR is the most promising approach. Digital PCR is quantitative, digital PCR is sensitive, even more sensitive than NGS, and it has a shorter turnaround time. We do not need to pull that many samples together before performing a run. On the other hand, digital PCR has the drawback of being able to detect one single mutation at a time. So with respect to NGS, I see digital PCR as a complementary rather than as an alternative approach. However, there is still a long way to go because we still need to carefully evaluate this method and to perform standardization.